this particular short little presentation, and there is a little handout as well in your package on this, is for all of us in the stroke centers around Alberta to get on the same page on what we should call these things. So we want to move towards the term stat stroke, okay? And this will mean three things. There's an acute stroke coming in, okay? You're within 6 hours, so we're changing the time window here, or it's a stroke on awakening. So we're no longer talking about a 4.5-hour window. This will enable patients to also gain access to endovascular therapy. And there's one or more red findings on the provincial stroke screen. So we've all seen that, and hopefully we're all using the provincial stroke screen. This is what it looks like, right? And you'll notice that there's color on this page, and there's these red findings. So is the patient incomprehensible or mute? It's likely a stroke. Does any of the arms fall rapidly rather than normal, or it just drifts down? And same with the legs. Does it fall rapidly, or is there no movement on there? And then the grip as well. Is there no grip? So this will really alert everyone, and it alerts EMS that this is a potential acute stroke, and it's a stat stroke. We must act immediately. Okay? So just and probably you guys have been calling it other things. There's lots of, it's a stroke, it's an acute stroke, it's an acute stroke within the window. If we all call it the same thing, we know what we're all talking about. So we're going to also hear about this Los Angeles Motor Scale, LAMS. Andrew will be coming in and presenting on endovascular. We're going to start to move towards also doing a LAMS assessment in the field, and Renee has been working on that, and we're months away from being able to train people on it. But really, in the next session, when Michael and Tom go up to speak, we also feel that we can do the LAMS earlier. So when it's a LAMS 4 or 5, there's a body of evidence that says that it's potentially a large vessel occlusion, and the patient might be a candidate for endovascular therapy, and we can start to arrange transport early, okay? So LAMS score assesses stroke severity. It's typically done in the field by EMS. It's quick and easy to perform. So again, a 4 or 5 implies that potentially this patient is a possible endovascular candidate. We can start arranging for transport. So this is what the LAMS looks like. There's 3 things you look at. Is the facial sign? If there's a droop, then it's 1 point, okay? The grip as well. If there's no grip, it's 2 points. If it's a weak grip, it's 1 point. If it's normal, it's nothing. And same with arm strength. So this is all stuff that is on our EMS stroke screen. It's fairly simple. It's actually faster than our EMS stroke screen. A triage nurse or RAAPID can walk through and do this. We will have EMS starting to do this in the field. It'll trigger a field call with the neurologist, and there may be cases when we bypass the primary stroke center to get the patient to an endovascular site. But ahead of that, we will be able to do this in your sites even before CTA is done, so that you can start saving those 30 minutes and getting transport ready. If it's not a large vessel occlusion, we'll just stand down. And this brings us to the terminology that's a RAAPID terminology. It's called red referral. So if a triage nurse does the LAMS, it's a 4 or 5, she can get on the phone, this is a red referral, and they can start arranging for urgent transport. So when you're speaking with RAAPID and it's a LAMS 4 or 5, you can say, yes, this is a red referral. And they can start arranging for transport, okay? And then, you guys will be doing a CTA if you can, and if it's a hemorrhage or it doesn't require transport or the patient gets better, you just stand down, right? But at least then we're not wasting time. We're working in parallel to get things done. So that's just a quick overview of some of this terminology. Stat stroke, red referral, LAMS, okay?